wanted to bring today's episode to the podcast talking all about reproductive immunology. And this is something if you have experienced recurrent pregnancy loss, if you're having implantation failure, if you've got diminished ovarian reserve and really you've been told that nothing's going to work, have we investigated further with NK cells, ANA? We're talking all about what to test for, and then some new cutting edge modalities that can be done in your fertility center, and really how this can improve pregnancy outcomes. Excited for you to listen to today's episode. Let's go. Hey, Dr. Marco, excited to have you on the podcast.
Thank you so much for having me, Sarah. It's a pleasure being here.
Yeah. And so if you can really share with us how you came to do this work. I know you're a colleague of our medical reviewer here, Dr. Labib. So let me just share with us how you came to do this work.
Yeah, Dr. Labib actually was my program director in residency. We share a lot of good experiences. He was one of the reasons why we were so well taught and so well trained during residency. And when I finished residency, a couple of options came up, and my main focus was on fertility and patients assessment pre-pregnancy. And this is why I ended up going into fertility specifically. I came here to New York, started fellowship, finished my training, and then ended up with a Rejuvenating Fertility Center that I opened with, I co-opened with Dr. Murphy, who is another one of our CEO and our pioneer here in New York City. And we ended up eventually also branching out in other states, including Connecticut, and hopefully more states later on.
Right. Awesome. Well, yeah, today we're going to talk all about reproductive immunology and really kind of some cutting edge services that your team is offering, and really for people to look at this completely differently. Obviously, we're doing functional lab testing, looking at, targeted diet and lifestyle changes. And I haven't actually had anyone from a fertility clinic on my podcast. I've been doing it for like over 6.5 years. So Dr. Labib had recommended you guys. And so I wanted to dig into this because this is a big topic right now, where anyone that's experienced recurrent miscarriage wants to, reduce complications during pregnancy, which is really everyone. And then people that are potentially, with diminished ovarian reserve, and what we can do to increase pregnancy outcomes. And so I just kind of wanted to talk about, so some factors that would really be for immune testing, like if someone's had some miscarriages, like what are some areas where you're like, okay, wait a minute, now we need to kind of dig deeper with some immune testing. What are you seeing there?
Yeah, so in general, for patients that there are certain general guidelines that fit all patients' criteria. And those include for patients with recurrent implantation failure, recurrent miscarriages, problem with immunity, autoimmunity specifically. But we feel also that there's a case-by-case evaluation. So, for example, for recurrent miscarriages, you need the patient to have 2 to 3 miscarriages in a certain amount of time during the pregnancy in order to be able to be assessed for recurrent miscarriages. But you are a patient, for example, you come into me and you've had 1 or 2 miscarriages and you don't want to wait for a 3rd miscarriage in order to be evaluated appropriately. Should we decline that testing for you? No, we counsel you. We counsel you on where the outcome of this testing can be and where this could lead us when it comes to evaluation and treatment. And if we're on the same page and we understand the consequences of that, we can proceed with the treatment. So there are the guidelines, which definitely are good to follow, but they're also a case-by-case evaluation. And on a daily basis, we have amendments of guidelines or new tests that come up that show that, hey, there's this small elements that we haven't evaluated before that makes sense to evaluate. When it comes to immunity, for example, there are on a daily basis, I'm sure you hear a lot of them, and we'll talk about them in a little bit in detail, but I don't know if you want me to talk about them now, but we can talk in general first, and then we can delve into. There are tests on a daily basis that show up that tell us, hey, this patient probably will need more treatment, or this patient will need certain assessment prior to her transfer or her getting pregnant. And this is why we tend to bend we tend to bend the criteria for evaluation of a patient most of the time.
Yeah, because a lot of times, well, it's like typically in conventional medicine, they'll like wait for you have three losses, right, before they go and do any other testing, and which is like devastating for let alone
Correct.
kind of going through three where nothing's been I shouldn't say nothing's been looked at, but a full investigation hasn't been done. We want to prevent that because the emotional heartache of going through, hey, let's wait for three. Like we
Yeah.
see people that have like five, six, like I have a woman that works for me and she's had 12 and she finally discovered, diet and lifestyle changes, made all these changes and was able to have both her children. But like the stress and the heartache of that is can't even fathom it.
Yeah, the mental and emotional aspect of all this also needs to be taken into consideration. One miscarriage can be devastating for a patient, where another one going through two maybe would not be as impactful. Obviously, it is a distressing event, but one patient can take it a little bit different than another. And even one miscarriage can sometimes be, as I said, devastating for a patient and might push us to do a little bit more treatment. Now, to be fair, that being said, the guidelines are set for a reason, which are made in the sense that if we do the testing on these patients, we'll probably find something. But if we do it on patients that don't fit these criteria, the likelihood of finding something is very, very, very low. So statistically, it makes more sense to make it on these patients. But when you are the patient that don't fit these criteria yet, you don't want to wait until you're in three miscarriages or go through all of that in order to say, hey, maybe now we should be tested. I'd rather be tested a little bit earlier. I know I might not fill all the criteria yet, but I would like to be tested earlier just to make sure to prevent it. It was a lot for me, and I don't want to wait that long. And it makes sense for those patients.
Yeah, the
And
people that have had, sorry, go ahead.
no, no, go ahead, please.
A poor number of eggs that were produced from a stimulated cycle. So sometimes people are just, I don't think it poor responder or canceled cycles and like just poor outcomes. And then all the embryos could be abnormally tested if they go down the testing route of how to dig a little deeper on that piece. Can you maybe speak about that side of things?
So are you talking specifically about patients that went through fertility treatment, did a retrieval, and had poor outcome? And your question is specifically on whether or not they should test? Is that your question?
Well, more for the reproductive immunology. Well, some of these methods we're going to be talking about, could that then like we're looking at it from the functional standpoint. So we're going to do diet and lifestyle and things like that. We've
Yeah.
seen people's follicle count comes up and their egg quality, all that improves. And I guess from your standpoint, from the reproductive immunology side of things, or is there anything then kind of that would be like a red flag for you to see that you would dig a little deeper, I guess?
Yeah, so there are also certain regional aspects of fertility that we see, like the environmental impact of fertility can be regional sometimes. So this is where we tend to tell patients, hey, you might benefit from certain reproductive immunology treatment or some certain lifestyle changes. Now, it is known for a fact that eggs and oocytes, even sperm as well, is affected by environmental factors. This includes the air we breathe every day, the chemicals that we are exposed to. And this is something as benign as candles, as perfumes, as a food that we eat, as also the water that we drink, the exercise, whether we exercise or not, and the general toxins that are in the atmosphere that we stay in every single day. So definitely lifestyle changes can impact in a big way the quality of the eggs. Now, I'm talking about patients who may, or the quality of the sperm as well. I'm talking about patients who might have normal everything, but this is the only problem. But also in patients that have abnormal parameters in certain fertility assessment, they could also benefit from treatment or changes in their lifestyle. Okay. And immunological treatments also can help in assessing and in bettering the outcome of fertility, whether it is in natural cycles or whether it is in IVF or any other types of assisted reproductive treatment.
We work with a lot of people that we see that have autoimmune disorders. So a lot of Hashimoto's, celiac, rheumatoid arthritis, a lot of irritable bowel disease too, Crohn's or colitis. And so like testing the ANA piece, like, so what would you, I guess, do there if you were seeing someone that's presenting with that and then looking kind of deeper for that piece?
So for patients that have an autoimmune disease that has already been diagnosed, the fact that they have an autoimmune disease increases their risk of having autoimmune diseases at the other places in other organs in their body. So we know that they have an autoimmune baseline. So their body is creating antibodies that is attacking their own cells. Once it is in one organ, they have a higher chance. It doesn't mean that they have it in other organs, but means that they have a higher chance. Also, patients that don't themselves have autoimmune, but they have autoimmune disease in the family also are at increased chances of developing autoimmune disease. For these patients specifically, there are two types of routes that we can take. We can either do an autoimmune panel testing and then treat based on that testing, or we can do autoimmune panel treatment directly. There are two approaches to this. None of them are wrong, and none of them has yet to have an established protocol, but both of them can benefit the patient. The autoimmune testing is an evaluation of blood test evaluation, where it will assess certain antibodies that are the most frequent or most frequently found in autoimmune diseases. It will assess certain aspect of autoimmunity like NK cells or CD4 cells. Those are that attack embryos or attack cells that are reproductive organs. And it will give you a certain treatment plan to increase your chance of fertility. The basis of these tests is not yet completely understood, and also the implication, the outcome of this test has not been completely elucidated. But they can still benefit patients, especially patients that have tried the conventional treatment. They have tried everything with the regular treatment, and they still have not had the outcome. Me and myself, as a conventional medicine physician, cannot say that we know everything. So there are still aspects in conventional medicine that do not fulfill the criteria or do not fulfill the need of patients. And this is where alternative or more treatment or functional medicine, holistic medicine can also help increase your success rates. So for these patients, they can definitely benefit from this testing. There's another approach where, as I said, we can do directly the treatment because that testing can sometimes be faulty. So it can sometimes miss certain antibodies. There are so many antibodies to test. Why are we choosing these ones? Because they're the most frequent. But what if those are not the antibodies that you have or that are causing the problems in your body? So doing treatments directly can sometimes also be helpful. Also, as we know with autoimmune diseases, antibodies can sometimes start as negative and then they can develop later. You can start developing the symptoms of a certain autoimmune disease and then develop your antibodies later, or the opposite. You can have the antibodies first without the disease and then develop the disease later. So the chronology of where the antibodies are and where the disease is not always a linear line. So testing might not be the best outcome. And this is where treatment prophylactically might give you a better results. So I give the option to my patients, but I usually recommend if you've had a baseline of autoimmune disease or have a history of autoimmune disease in the family and you've had problems with fertility and you're seeking treatment, then maybe doing the treatment of immune problems might be the best outcome for you. Does that answer your question?
Yeah, it's good to be able to dig deeper on this piece. I think, what I'm seeing is many people with an autoimmune disease, they're being rushed towards IVF, and then the antibodies, maybe for instance, they have Hashies are like sky high, and then no one's still really thinking that that's a problem. The body's under attack, it's attacking itself, and we like the antibodies below 10. And then another one where people are, I should get to that in a minute, but the natural killer cells. But we see another one we also see is a lot of people where, hey, I had my first baby, no problem, easy pregnancy, everything was good. And now all of a sudden, I'm trying to have my second, and the AMH is super low, the FSH is high. Maybe you got a diminished ovarian reserve diagnosis. Like all of a sudden, it seems like the body is just like crashed down and it came out of nowhere. Obviously, you just had, sustained life, had a pregnancy, postpartum, maybe you're breastfeeding. So secondary infertility to make sure some proper testing is done for that. What are you seeing for that one?
As you said, this is called secondary infertility. It's actually as common as primary infertility when it comes to percentages. Now, secondary infertility can have different causes as well. So you mentioned one of the causes, which is low ovarian reserve, elevated FSH, but there can also be other causes. It can be due to problems with the regularity of the cycles. It could be problems with inside the uterus. It could be problem with ovulation. It could be new onset male factor infertility. So there are different causes for secondary infertility, and secondary infertility warrants evaluations just as diligently as primary infertility. completely different etiologies sometimes, but you still have to check for it and make sure that you're evaluating appropriately. Now, if the appropriate evaluation was done and we have certain causes for infertility, I do understand where, again, conventional medicine would want to go straight forward to IVF. IVF has a high success rates, but that doesn't mean that everyone needs it. That doesn't mean that you need to go through all the medication for the IVF, all the procedure, pay so much money. It's so expensive to do IVF in the US. So you might not need it. And I understand it's a high success, but it's also good to maybe give the patient an option and try with other treatment before that. What I recommend to my patient, as I said, is start with the evaluation. If you find something that needs fixing specifically, then we can start fixing that part. If not, then maybe doing something with lifestyle changes and doing some more holistic approach first makes sense, and then afterwards move forward with more advanced treatments like IVFs or assisted reproductive technologies.
And then I think in the bigger buzzword now is natural killer cells. People are like, oh my goodness, what are my natural killer cells? They're elevated. Maybe that's why I'm having, repeat miscarriage, or that's why I can't conceive. So maybe let's just talk about natural killer cells, what you're seeing there, and why it's important to test those. It still is controversial. It's like new territory, but what are you seeing?
So natural killer cells are important. They're, as you said, a fairly relatively new term, or at least new not favorite term, but new term that patients use a lot, and patients tend to look up a lot and want to evaluate. For a patient coming in from the beginning wanting to test NK cells, I would definitely say this doesn't make sense. For me, it does not make sense because most probably we won't find what you want to test for. So I won't have the results for you. But for a patient that has exhausted her treatment options with other fertility treatments and wants to evaluate her NK cells, it is a good option. Again, the problem with NK cell evaluation is that sometimes they are high, might not be correlated with clinical evidence, and sometimes clinically makes sense that it is positive, but the lab testing comes back as normal. So again, it becomes a little bit difficult to correlate clinically. My recommendation, again, would be probably to treat prophylactically, regardless of results of the NK cells. Most of the time, the treatment for this is not as extensive as other treatments. So why not just do the treatment if it's not that hard on the body, and avoid all the unnecessary testing that might not give you the proper results. But in some patients, if they want to do the testing, we'll go for it, and we do the testing in these patients. But it has to be for patients that have had definitely multiple treatment modalities. It's still not elucidated to go directly with that without having proper modalities first. And I understand where you're coming from, Sarah, with the answer that hey, I want to try to do this prior to doing treatment, which makes sense. But so far, I don't have a protocol for that. So to be able to tell you, let's do it, and this is the outcome of this is what we're going to test, this is what we're going to treat, this is what the outcome is going to be. We don't have that yet as far as studies wise, but we might have it in the future. So we might be missing that gap for now. But for now, we still are going through modality of treatment first. Unsuccessful, then maybe doing alternative testing.
Yeah, like if there's recurrent implantation failure or recurrent miscarriage,
Correct.
then to dig into this piece that might not have been missed. But if you're even for the NK cells to do elimination diets and autoimmune protocols, with a diet there, and then looking at your gut microbiome, some of that stuff can then reduce it if it is high. Because sometimes people get stuck on the number. Well, how do we then improve it?
Correct. I don't want patients to be stuck on the number. This is my main quote unquote issue with these testing, is when patients get stuck on a number. Obviously, numbers are important, but numbers are just there so that we can do the treatment and manage their cases. They don't dictate your success rates all the time. There are different treatments for autoimmunity or for immune treatment during pregnancy or during fertility treatments. And those can involve multiple modalities that we can speak about if you want. These are including the EMA and ALICE, which is part of the ERA. There's also the Intralipid treatment. There's uterine PRP that can help as well. There's medication that can help, including prednisone, baby aspirin, Lovenox. All of these treatment modalities can increase your chances by decreasing your autoimmunity or decreasing the way your body might attack any external factor, including the embryo or itself.
So let's start with the lipid infusion. What is
Yeah.
that, and how can that be, and who does that help?
So intralipid infusion is a high content fat infusion. Basically, it's an IV infusion that is given in certain times during the cycle to try to keep your immunity and blunt your immunity at a cellular level. It does not increase your chance of catching diseases because patients are always worried, yeah, I'm blunting my immunity. Does that mean that I'm gonna now be more prone to catching certain microbiomes or microorganisms? The answer is no. Just blunt it on a cellular level so that basically the NK cells don't attack your embryos when they are transferred, basically. Can also help in natural cycle for implantation, but it's more studied in IVF cycles and transfer cycles. The way that there are different protocols to give the intralipids that have been studied. Some of them are so most of them are during the transfer cycles, but some of them are on a weekly basis and they stop at the transfer when it's done. Other ones are on a certain time of the month, right around the transfer, and they stop afterwards. And other ones are on a weekly basis, and you continue throughout the pregnancy until around 9 to 10 weeks or 11 weeks of pregnancy. The way that we have been using it mostly with patients is that it makes sense that once you start it, you would want to continue it throughout the pregnancy, at least not throughout the pregnancy, but at least throughout the first 8 weeks of pregnancy or 7 weeks of pregnancy. You want to make sure that we have crossed the heartbeat part, we have an embryo that is growing, and then we can stop it afterwards. The way that we do it is that we do it on a weekly basis. Once when patient is on estrogen for preparation for transfer, once when she's on progesterone for preparation for transfer, and then once when she is pregnant, then weekly after that. Okay, and it is around a 1 to 2 hour infusion where patients just sit and they have the infusion line and they're done with it after that. It's not a medication without or treatment without complications. Some patients might experience some difficulty breathing, some back pain, some leg cramps, and as I said, it's a high content fat. So as other medication can also have allergic reactions. So the first time it's done, it needs to be done very slowly. It needs to be done very carefully with the presence of an MD there, just in case you have any reactions. And most of the reactions are due either to rapid infusion or to allergies from the patients. Otherwise, healthy patients don't have that much of a reaction to it, but it's still better to observe.
So it's the egg yolk, phospholipids, and then soybean, and then glycerin.
Correct. And patients who have allergies to soybean, for example, or soy can't take it. Patients who have allergies to eggs, they can't take it. But allergies to eggs are also, there are a lot of other medications that are also allergic to eggs. So we also have to eliminate other ones. Soy is the one that is just unusual in this one.
The next one you have, so there's a lot of, actually we'll get into that one in a minute. Let's talk about vaginal ozone. So first of all, there's a lot of kind of buzz about ozone. What is ozone therapy, and then how do we use it vaginally, and who does it help?
So we actually have ozone therapy. Dr. Murray, the co-founder of RFC, was one of the pioneers for ozone therapy. So ozone therapy is an oxygen therapy. So the ozone layer above the earth is basically made of 3 oxygen molecules, whereas the air that we breathe is made of 2 oxygen molecules. Most of the inflammation in our body is due to free oxygen radicals. Oxygen radicals, what they do is they attack cells and cause breakage. They cause breakage in the membranes of the cells, breakage in the DNA of the cells, and this is where quote unquote inflammation comes from. Now, the way that ozone treatment works is that the treatment that we have is a capsule. Patients sit inside that capsule, it closes on them, and they have ozone infusion on their body and inside with a catheter vaginally. The ozone infusion will be seeped into the skin transdermally, so through the skin and also through the vaginal area. Okay. Once it is inside, the 3 molecules of oxygen will go to that free radical of oxygen and will neutralize it. So 3 plus 1 will make 4, and then they split into 2 oxygen molecules, which are the oxygen that we breathe. And that oxygen get basically dissolved into the bloodstreams and goes as oxygen. So basically neutralizes the oxygen-free radicals that are in your body that is causing inflammation. And this works for uterine and ovarian and other inflammations as well. It has been used in other treatment other than fertility, but most recently in fertility, the studies that we have been pioneered by us.
Yeah, a lot for immune system too, as well. So,
Of course, immunity causes inflammation the same way as well.
right. And so looking at, so you're primarily using it for people over 35, or is it, do you, where are you recommending it for someone? Hey, I think you should, should look at the ozone therapy.
We have different studies going on right now when it comes to ozone treatment. And it's also for different indications. We have used it as a study for recurrent implantation failure, and it has been shown to help with implantation failure. We have used it for patients that have had problems with egg quality, and it also has been shown to be successful for egg quality. We have two most recent studies. One is about the success of ozone therapy in increasing sperm parameters in patients with abnormal semen analysis, and we are actually presenting that in the conference, in the ASRM conference that we had last year and this year, and as well as another study about endometriosis and the effect of ozone on endometriosis. That is still an ongoing study, so we don't have the full outcome of it, but so far it's also promising. So, and basically, any disease that could be due to inflammation can benefit from this. To what extent is the question? And so far, have been having good results with that.
Yeah, we do as part of our protocols, we do vaginal microbiome testing as well, and this ozone can actually help with vaginal infections too, because we see a lot of people with bacterial vaginosis, and the vaginal microbiome is, it can be a mess, right? And so we're doing gut microbiome, which then will positively impact the vaginal microbiome, and then doing protocols there. But some studies talking about how ozone can be helped with vaginal infections. Anything you're seeing?
Correct. I've seen patients report improvement in their vaginal microbiome health. They feel better. I haven't had basically a patient be tested pre and post for vaginal infections or for culture of vaginal area before and after ozone treatment to assert to that, but just by the fact that it's helping decrease inflammation and decrease your immunity overproduction, it can help regulate your bacterial growth and basically regulate your microbiome.
And then so ovarian PRP and uterine PRP kind of are sort of some well, that it's a lot of people talking about ovarian PRP right now. It's sort of, I guess it's the Wild West, where sometimes people are spending like $10,000 to $500, and it's all over the place right now. And so let's talk about uterine PRP and how that helps someone that's dealing with the reproductive immunology side of things. What would you say there?
Yeah, so uterine PRP, so two different modalities, ovarian PRP and uterine PRP. They're completely different due to they are used for completely different cause and a completely different outcome. But the preparation is the same. It's still PRP. So PRP is platelet-rich plasma. So it's your own blood, it's the patient's own blood. We take it from her and we have a certain preparation method that extracts the platelets out of the blood. Platelets have growth factors, and they have cytokines, they have some more anti-inflammatory markers that can help with the environment that they are put in, depending on where they are put in. The preparation method of PRP is very important because there are different preparation method, and the one that we recommend is the one that does not use any activators or any chemicals, including calcium, heparin, etc., because those we are doing something to try to help, and we still don't know if that can impact negatively the outcome of the cycle. So we'd rather not do anything that might harm. At least when we put the blood as it is, just by sheer physical activation, that will either have the positive outcome or no outcome. At least it won't have a negative outcome. So the preparation method that we recommend is with no added chemicals, just activation of the platelets by physical centrifugation. Okay. Now, there are, as you said, two types of PRP. There's the uterine PRP, there's the ovarian PRP. The uterine PRP is basically an infusion of PRP inside the uterus. So it's as if it's an insemination or a water sonogram. And instead of putting water or sperm, we put basically the PRP inside the uterus. The way that it can help depends on also the reason why we're doing it. There are different reasons why we do it for the uterus. There are patients with recurrent implantation failure. There are patients with history of thin lining. There are patients with a history of scar tissue inside the uterus or Asherman syndrome. And those will react differently to the uterine PRP, or at least the effect of PRP will be different in each case. For recurrent implantation failure, for example, PRP has been shown to increase the receptors or upregulate the receptors for progesterone and estrogen inside the uterus, therefore increasing your implantation rates with transfers. When it comes to Asherman syndrome or scar tissue, or when it comes to thin lining, the PRP itself, the growth factors will help healing of the endometrium and the growth of the endometrium, the thickness of the endometrium. So depending on the reason why we're doing it, your effect will be different. Obviously, it will have all the effect at the same time, but what we will see the outcome will be due to one parameter or the other, depending on the cause. So this is for uterine PRP.
And just for the uterine PRP, how far ahead are we before transfer retrieval? Like, when are we looking to do? Do we need to do a number of them, or what does that look like?
So it also depends on the cost. So if we're doing this because we have thin lining, then we want to do it early on in the cycle to try to have that PRP be absorbed by the endometrium enough way ahead enough so they can thicken the endometrium. Okay, so this is, for example, for patients that have thin line. For patients that have recurrent implantation failure, their problem is not in the thickening of the lining. Their problem is right before the implantation. So the recommendation is to do it 24 to 78 hours, 72 hours prior to the transfer. So we start the progesterone, and then after the start of the progesterone, we do the PRP. For patients that they have Asherman syndrome, we might need to do it multiple times ahead on a weekly or bi-weekly basis, every 2 weeks or every week, much ahead, so that we can help the lining heal and help grow the endometrium thickness.
Anything you're seeing clinically there, kind of some findings on the uterine PRP? And
uterine PRP has already had Cochrane reviews and meta-analyses that have shown that it's successful in increasing lining thickness and implantation rates in patients with thin lining, and patients with recurrent implantation failure, and patients with Asherman syndrome or scar tissue history. So we've had a lot of success with that, and I think many clinics do that and have had successful outcome with that. It's definitely a treatment that is used after you use the regular modality. So you start with your regular treatment for thin lining, or for patients with transferring, but for patients that have had thin lining problems for a while, and patients who have exhausted that treatment and want to use something different or want to try something different, then uterine PRP is one of them. Now, we actually are presenting in the upcoming ASRM in Denver, Colorado. We're actually presenting our study where we use the hysteroscopically guided ultrasound injection of uterine PRP directly inside the lining. So the one that I was talking to you about was an infusion, but there's also an injection of the PRP at the baseline or basement membrane of the endometrium. That could have a more lasting effect than if you just infuse it inside the uterus. Because if you infuse it, by the end of the cycle, when you have a period, it goes out. But the one that is injected inside of the basement gets absorbed, and it can last with an effect for 3 months, and you can have that cycle outcome multiple times instead of doing it one time and that's it. It's done. You don't have the effect anymore. So we're presenting this data at the upcoming ASRM conference, and it has been shown to be successful in increasing thickness of the lining as well.
Yeah, and we're seeing clinically, obviously, with diet and lifestyle changes, where people coming on thin lining, and then we start making all these changes and we're improving it. So this might be a nice add-on to then further do that, right? But it's, to me, not skipping all the basics, just go running off to doing a uterine PRP. We still got to do all the foundational side of things, which that'll open a lot better success, right?
Definitely a combination. As I said, medicine is not a one-faceted thing. We have multiple aspects that we have to tackle at the same time. Definitely diet and health, and making sure that emotionally, physically, and medically you are fit to continue with this treatment is most important. So health-wise, you have to make sure that you're stabilized. You work on your diet, you work on sometimes some elimination in the diet, and you'll have a better success rate for sure, even with those studies.
And then the ovarian PRP, which there's a lot of talk about. I've done a little podcast episode on this one, talking about, well, sometimes we're maybe doing it. We're not anti-IVF or anti-PRP or any of that piece, but it's like you maybe doing it premature, where you're then putting inflamed cells back in the ovary. So ours is like reduce inflammation from the, like we're talking, feel like a broken record, but the diet and lifestyle, and then potentially go and do that ovarian PRP. So let's talk about how that can be helpful for someone. What are you seeing clinically there?
Yeah, I understand your concern about doing it too early. Honestly, in my opinion, I haven't seen it being done too early. I actually have seen it more being done way, way too late. We do ovarian PRP. We are one of the biggest clinic that does ovarian PRP for patients. So we tend to see patients when they have exhausted all their possible outcomes with either with IVF, using their own eggs, multiples. They have seen multiple clinics. They have had multiple cycles, and they still haven't had the outcomes that they want. And these are the patients that I would sit down with and discuss ovarian PRP with. I wouldn't just say to a random patient who is 25-year-old or 30-year-old who tried one time and didn't work, IVF didn't work, or even didn't even try IVF, tried naturally, and then hey, let's do ovarian PRP. It's not how we operate. It's definitely a treatment that is done after you have failed other modalities, whether it's health lifestyle changes, whether it's dietary changes, whether it's treatments with or without assisted reproductive technology. So after you've exhausted this is when we recommend patients to go ahead with ovarian PRP, and they have to fill certain criteria. They have to have had they have to have certain numbers of hormones. They have to have certain numbers of follicles, for example, or they have to have there are different criteria depending on the case that they have to fill. If they don't fill these criteria, we don't move forward with ovarian PRP. Now, we counsel the patient. I think the most important is to counsel the patient and give them their success rates. If they are comfortable with those success rates, they want to proceed, knowing those success rates, then we can proceed. It's also not good to always say no to patient, or this is not going to be working for you. But as you said, doing it too early might also be a problem. So we tend to not see it too early, honestly. We tend to see it way, way, way more too late.
I think because I'm working with people with a premature ovarian insufficiency, diminished ovarian reserve, and people are just like, sorry, you're not going to do IVF. You better go straight to that PRP. And so that's kind of what I'm seeing from what they're being told, and they're doing multiple ones. It doesn't work, and then they get frustrated. What is there an age cutoff? Because I was seeing some clinics doing like people in their huge push for in the 50s. I don't know what you're seeing on any of that piece.
So I think if a patient wants to try, we can try. They have to be given their percentages. In their 50s, and we've had actually a couple of patients have been, not more than a couple actually. We had patients that have been successful even in their 50s. They even have natural pregnancies or IVF pregnancies. So to just say based on an age cutoff that hey, you don't fit the criteria, you're out, I don't think this is correct. But patients should be given their percentages. They should be told, hey, this is your percentage at this age. Obviously, and patients, we know it and patients know it, that donor eggs or doing something different, not using your eggs or adoption even would obviously be more successful for you. But these are your percentage with your eggs. And some patients have an attachment to their own eggs, their own DNA. They want to try. They have never even been able to try ever in their life. This is their first time trying. I have had so many patients who just got into a relationship that they feel comfortable at the age of 45 or 47. And are we going to just deny them the treatment just because of their age? Then I don't think this is the proper way to deal with medical treatment. So we do offer them the option, but we also tell them that your success rates are different than a patient who is 35 and trying this, who has tried IVF, but which has not been successful and wants to do an alternative treatment, which is PRP. We give them their percentage, we tell them the outcome, we give them our experience with that, and we tell them, if you want to go for it, we will help you as much as possible, and hopefully you'll have success. And we've had success, so it is possible.
And what are you seeing with what's the procedure there for the ovarian PRP? What are you seeing? How does it just kind of run us through it?
Yeah, so for the ovarian PRP, patients basically come in the same day. It's a same day procedure. When the blood is drawn, it's a venipuncture through the hand, just like when you do any blood draw. We prepare the blood. It takes 1 to 2 hours to prepare the blood in total, depending on the facility's readiness to do it. And then once we have the PRP ready, it is injected vaginally through an ultrasound probe. So it is just like an egg retrieval process. So if a patient's had egg retrieval, what we tell her is that it's similar to an egg retrieval process, but instead of taking the fluid out of the follicle, we are injecting the PRP inside the ovary. So this causes a little bit of a distension of the ovarian tissue, which could be a little bit more painful than the retrieval. And this is what I tend to counsel my patients about, because actually almost 40 to 50% of our patients do it under local anesthesia even. So we have patients that decide they don't want to sleep, they don't like to sleep and take that propofol medication or have sedation for it. So they'd rather stay awake for the procedure. And for these patients, I just let them know maybe you've done retrievals under local, but this might be a little bit more uncomfortable, and doing it under IV sedation might be helpful. And it's the actual procedure, the actual injection of the PRP is a quick procedure. It's if you're asleep, it will be a 10-minute procedure where we inject the PRP inside the ovaries at multiple locations. It's very important where it's done and how it's done. The center of the ovary does not have any follicles inside of it, just had the blood vessel flow. So it's very important to inject the PRP in the cortical area of the ovary where the follicles that we are targeting are present. So it's injected there deep enough, but not inside the middle of the ovary. And it should be done at multiple locations. We inject approximately 3 to 4 milliliter in each ovary, so a total of maybe 6 to 8 milliliters of PRP. It also depends on the size of the ovary that we're injecting in. Some ovaries are smaller, some ovaries are bigger. They can take up a little bit more PRP. And it also depends on the amount of PRP we got from the patient, of course.
Okay, so we got the intralipid infusion, we got the vaginal ozone therapy, we've got the uterine PRP, the ovarian PRP. Did we miss anything? Anything else you wanted to share that would be helpful?
You spoke about also microbiome. I have a lot of patients requesting to test like the Emma and the Alice. I don't know if you've heard about these treatments or these testing. These are also part of endometrial biopsy assessment. I'm not so far fond of them when it comes to how we would handle it, because I can get that information also, for example, from an endometrial biopsy or from microbiome testing. But if a patient asks and requests them, I would still do them and follow the recommended treatment in the test, basically.
And then, like as part of our protocols, we're doing supplements, so omegas and vitamin D. Is there anything that you wanted to share about those? Is that something you discuss with your client, your patients? How omegas can help with NK cells inflammation, vitamin D, obviously, but yeah, anything you wanted to share there?
Yeah, definitely. When it comes to multivitamins and vitamin regimens, especially for patients that have had, so the way I see patients is usually patients have either, tried for a long time and they're ready to move forward with assisted reproductive treatment, which is a little bit different from when you probably see patients. They're still maybe before that and they want to get things fixed before they even need IVF sometimes or assisted reproductive treatment. I see them usually when they've already done all of that, and they want to move forward with some treatment modalities. What I recommend to patients all the time is that multivitamins can help you regardless of where you are in that phase, whether it's pre or post. If you haven't started yet, it can definitely help. Even for patients that have had IVF cycles that are unsuccessful and they want to go into another IVF cycle and they haven't been on these regimens, it will definitely help increase your success chance. Now, the ones that I would highly recommend, vitamin D has been directly correlated with fertility and fertility success. So I would definitely recommend 1 to 2,000 units of vitamin D daily, both men and women. If the couple will include a man and a woman, but definitely take both parties. And CoQ10 can also help by decreasing inflammation and increasing your likelihood of producing good quality egg and sperm. Some omegas can help as well with decreasing your immunity system, your autoimmunity system. And there are other supplements that can also help, like magnesium, zinc, and all that. But the main ones are the ones that I mentioned initially. And anything that is added that you feel like you want to take as a patient, you can go ahead. But for me, the two most important or three most important ones are vitamin D, CoQ10, and omegas.
Great. And obviously a prenatal with methylfolate. Okay.
Of course, so prenatals.
Right.
I'm not.
Right.
We're not.
Yeah.
We're not even considering prenatal methylfolate. Of course, it's recommended. Any patient that is even attempting pregnancy, whether with or without any fertility problems, we're talking about the 400 microgram minimum dose, of course.
And then, so they can find you at rejuvenatingfertility.com, and we will have that link in the show notes. Anything you wanted to share there about your where they can find you, or kind of what else you do at your clinic?
Yeah, sure. Well, thank you for sharing our link. Of course, they can also find us on social media. Of course, we have our own page. We have the clinics page. We have my page. My co-founder, Dr. Murphy's page that they can find there as well. What I would want to share is that if I were a patient, I would want someone as a physician to hear me and understand that I understand there's medical treatment, but I also want to work on a health perspective when it comes to fertility. I believe that medicine or conventional medicine is important, but there are a lot of aspects of conventional medicine that are not completely looking at the patient as a whole. And this is where functional and holistic medicine can definitely be an add-on. I'm not sure that one of them alone can be successful. It might be successful for some patients, one of them alone, but most patients will require a combination of both together to be able to have the highest success chances. And we're seeing more and more of that trend, especially in the US. And I'm very happy to see that because patients are taking care of themselves on a health-wise basis, and therefore they're seeing better results when it comes to any medical treatment that they're taking.
Absolutely. Any final thoughts for us to hear today, Dr. Marco?
Sorry, I didn't hear that.
Oh, sorry. Any final thoughts for us today, Dr. Marco?
No, thank you so much for having me, Sarah. It was a pleasure speaking to you. And again, any questions that you might have about what we spoke about today that you want to discuss later on, you feel more than free to reach out to me. It was a pleasure being with you here today.
Awesome. Thank you so much for all the
You're
work.
so welcome. Have a good rest of your day.